Thank you for joining today's webinar. I'm Ferris Taylor, Executive Director of the Healthcare Executive Group. Today's presentation, led by our HCG Gold sponsor and partner, CareCentrix, is titled The Future of High-Value Care, Advancing the Home Health as a Post-Acute Alternative. We want to welcome all of you, and let me mention a few housekeeping items. All participants will be on mute. We will have time at the end for Q&A, so please type any question that you have at any time during the webinar into the question box in the lower right-hand corner of your screen. And you can visit carecentric.com for more information on today's webinar and also other important healthcare topics. Briefly, the Healthcare Executive Group is a national network of healthcare executives and national thought leaders celebrating our 30th year and working together to make positive changes to healthcare. We interact regularly across multiple channels, such as these webinars, periodic executive roundtables, white papers, social media, newsletters, and our annual forum. By facilitating knowledge-sharing events like today's webinar, we help shape and advance industry-leading discussion. You can learn more about our thought leadership and networking opportunities at our website, hceg.org. Throughout the year, our members discuss and deliberate critical technology and innovation opportunities, issues, and challenges. Each year during our annual forum, we formally vote the HCG top list for the next year. Today's webinar will cover several of these HCG top 10 issues. You see here on our 2018 list, value-based payments, cost transparency, population health. Those are items number 2, 3, and 4, all of which are impacted by post-acute and chronic care. You see on the next slide, these top 3 ranking issues also carry over to the 2019 list. Item number 4, number 8, number 3, the order changed slightly, but in essence, the issues of post-acute and chronic care management are some of the very fabric and infrastructure of most everything that we do in healthcare. Next slide. Today's webinar on this topic will be led by Dr. Michael Cantor and Dr. Karen Johnston. Dr. Cantor is Chief Medical Officer at CareCentrix. He's a geriatrician and an attorney with extensive experience in designing and implementing population health and quality improvement programs for health plans and healthcare providers. Dr. Cantor still sees hospital inpatients on weekends. He trained in internal medicine at Beth Israel Hospital in Boston and did his geriatrics fellowship at Harvard Medical School. His degrees in law and medicine are from the University of Illinois. Dr. Karen Johnston is the medical director at CareCentrix. Dr. Johnston trained as an internist at the University of California, San Francisco, and started her career as a partner in a 50-physician multi-specialty practice group practice. She subsequently shifted positions as a medical director and chief medical officer at cardiovascular prevention programs ranging from academic to commercial to venture capital-backed startups. Most recently, she co-founded a self-funded startup, eMed Bracelet, an electronic personal health record. She has a passion for global and health and serves on the board of Bridges to Community, a non-governmental organization working in Nicaragua and the Dominican Republic. Let me turn this presentation over to Dr. Johnston.
Thank you, Ferris, and thanks to all of you who are joining us on this webinar. I'm pleased to be joining my colleague, CareCentrix Chief Medical Officer, Dr. Mike Cantor, in speaking with you about the opportunities in the post-acute care sphere that improve clinical outcomes and decrease cost while improving patient comfort. I'll set the stage today by briefly reviewing the current landscape in post-acute care. Then Mike will review the proposed changes to allowable benefits for Medicare Advantage plans and illustrate how those changes could benefit typical patients. Next slide, please. At CareCentrix, our vision is a world where everyone can heal or age at home. For those of you who don't know us, we've been home care benefits managers for over 20 years, and for the last several years, we've run a 90-day post-acute care program, all with the purpose of supporting our vision by supporting care transitions to the home and then care in the home. Next slide, please. This is a complicated slide that illustrates some of the many problems in the post-acute world today. Namely, there is tremendous chaos, confusion, and waste in the status quo. The discharge path of care is often not optimal. Many skilled nursing admissions are not necessary if adequate support had instead been provided in the home. Here I conservatively show 8 to 10% of SNF admissions are unnecessary, but depending on the market, we've seen much higher numbers. We'll get into that variability in a minute. For inpatient rehab transfers, or IRFs, the percent of unnecessary admissions is even higher than for SNFs. Once patients are in a facility, there often aren't enough safeguards in place to prevent a readmission. Many of those readmissions occur in the first few days after the transfer, typically due to poor communication between facilities. Medications are missed, the existence of medical conditions are not passed along or incorrectly communicated, for example. And for patients who are discharged home, the situation is still challenging. Again, there are communication failures at the time of transfer, as well as insufficient orders for home care services in at least 30% of the discharges to the home. Of note, of total readmission expense, only 20% comes from patients who were discharged to a SNF. That's the area that gets most of the attention, whereas 50% of the readmissions actually come from patients who were discharged home without any care. At CareCentrix, we approach these issues comprehensively. Our in-market nurse liaisons work with patients, families, physicians, and discharge planners prior to hospital discharge to identify the optimal post-discharge setting. The goal is for patients to be discharged to the lowest acuity setting that is appropriate, ideally to the home, and to facilitate transitions to keep patients healthier and less likely to be readmitted. Home care services and durable medical equipment are coordinated prior to discharge to the home. Once patients are home, our nurse coaches work with them to ensure they understand the red flags of their conditions, that their caregiver is supported, that meds are reconciled, follow-up MD appointments and transportation are verified, and food security is determined. Next slide, please, Farzana. Thank you. I think this audience is well aware that post-acute care costs represent about 25% of spending for Medicare Advantage plans. In general, Medicare PAC costs have doubled in the last decade. And additionally, the variability in costs of post-acute care is tremendous. And variability is one of the most consistent findings noted when evaluating Medicare spending. 73% of all regional cost variability in Medicare is seen in PAC spending alone. This is true despite controlling for case severity rates and the cost of living. It's unacceptable, and payers are determined to bring the variability into alignment and the costs under control. Next slide, please. So it's well established that a huge potential driver for controlling costs is to discharge to the home rather than to a facility whenever it's medically appropriate to do so. Discharge settings account for a significant proportion of the variability we were just discussing. Study after study has shown that for elective procedures like joint replacement, discharges directly to the home save approximately $5,000 per case. Clinically, the outcomes are at least as good as for patients who recover in a facility. I'm going to give you one example. Last year, JAMA published the results of a prospective randomized clinical trial from Australia. The authors looked at outcomes for patients with uncomplicated hip replacements in two different settings: monitored home health versus inpatient rehab. The average age was 67, and there were 165 patients in each arm. At 26 weeks, by objective measurement, there was no difference in the 6-minute walk test. And subjectively, patients reported no difference in pain nor function at 26 weeks. There was a trend toward more complications in the inpatient group, but it didn't achieve statistical significance with this sample size. Next slide, please. But when you do discharge to the home, it's key to keep patients adequately supported. Earlier, I touched on the fact that 50% of readmission cost is due to patients who are discharged home without any services. This slide looks at this phenomenon in the context of total post-acute care spend. You see that only 40% of total PAC spend is attributable to PAC facilities, whereas 60% of the spend is on patients who are discharged home. The biggest driver of this cost is readmissions. Those discharged home without services account for 25% of all PAC spend, or 50% of all readmission spend. We can and must do better than this. Next slide, please. Earlier, we looked at outcomes for patients who were discharged home with services versus to a facility after elective joint replacements. But what about complicated medical patients? And what about the cost of adding home health services? These are patients with complex clinical conditions who may be overwhelmed by their recent hospitalizations. They're weak, possibly drowsy, and often scared. They may be on meds that increase confusion. They may be diabetics who have had their medication adjusted in the hospital, and which, once they're out of the acute setting, may have lightheadedness from hypoglycemia, for example. For these patients, adding home health services can decrease total costs by preventing readmission. An analysis was done by Avalier in 2009 looking at 3 chronic conditions: COPD, pulmonary disease, diabetes, and congestive heart failure. The authors compared the cost for clinically similar patients who were discharged home with care versus those discharged to a PAC facility. Across all 3 conditions, they noticed anywhere from a $5,000 to $10,000 savings with patients who were discharged home with care. The amount of the savings varied with the severity of their condition. In other words, the more complex the case, the greater the savings when home health services were added. And the savings came from 2 areas, both eliminating the facility fee and reducing readmissions. In other words, the quality was better at home, and adding home health services reduced total costs significantly. That study was done in 2009, but this year, the American Journal of Medicine published a report that came out of the Cleveland Clinic, where they showed a retrospective analysis of their complex medical patients who went home with care versus those who were discharged home without services. They found the same thing. After 1 year, those patients who received services incurred a mean adjusted savings of over $6,000. Of note, they also had a significant decrease in readmission and in death. In other words, they had better clinical outcomes as well as cost savings when home health services were added for these complex medical patients who were discharged home. Next slide, please. So to sum up my brief discussion of the current opportunities in PAC, we can make changes that will improve clinical outcomes and save money by following patients through their post-acute journey. 1, by managing the discharge setting choice. Patients need the best type of setting and the best provider within that setting. 2, for those who are discharged to facilities, we need to manage the length of stay and the level of care assigned. Every effort should be made to get those patients home as soon as it's safe to do so. Lingering unnecessarily is both unhealthy and wasteful. Part of the oversight of facilities is to verify that the level of care assigned is appropriate, because you don't want to allow for the temptation to upcode. That's a real issue. We've seen reductions of in the neighborhood of 50% in acuity levels by evaluating necessity. 3, with a coaching program that supports both the patient and the caregiver, readmissions are reduced by minimizing the confusion that far too often accompanies discharge to the home. In addition, filling in any gaps in what the what resources the patient has to adequately care for themselves. And 4, finally, you need to manage the services and the equipment that the patients require. You need to validate receipt, avoid waste, and ensure quality. So I've spoken to you about what we do today. Dr. Cantor is going to address opportunities to do even more to achieve our vision of healing and aging at home. So Mike, I'll hand it over to you now.
Thanks, Karen. Good afternoon, everybody on the East Coast, and good morning to those of you further out west. Thank you for joining us for this presentation. As Karen mentioned, our focus is really in figuring out how do we provide better care for patients? How do we help them accomplish their goals? And when you ask the question, what do people really want? The answer is people want to be at home. They want to be able to age in place and stay in their homes. They want to be able to heal at home if they've been sick or recovering from an illness. And even if they're facing serious illness, they prefer to die at home. Unfortunately, when you look at the data, clearly people don't always get what they want. As Karen mentioned, in the case of post-acute care, you see people going to skilled nursing facilities more often than they need to, or inpatient rehab more often than they need to, and coming home without the services that would support them and recovering completely and effectively. Why is this? Why do we struggle, even though we know this is what people want, and you also heard great results from Karen for sending people home sooner? Why is this not happening as much as it could? Next slide, please. The reality is that there are several barriers to providing enhanced home services. And this goes beyond post-acute care. This is really trying to understand what happens to people who are aging in place. For many people who could use some help at home with homemaking chores, for example, cleaning or meal preparation, someone to make sure that they're doing okay, taking their medications properly, there just isn't a payment source for many of those kinds of services. Traditionally, Medicare has only paid services that are related to a skilled need. In other words, that are associated with an acute episode of care and that improve the patient's health. That's been the traditional standard. I'll talk in a minute about why that's so important and what may be changing in the near future. Medicaid, on the other hand, another government program, but one that is shared, costs are shared between states and the federal government, unlike Medicare, which is federal government only. Medicaid also provides care for many low-income people, and as you're all probably aware, has been expanded in some states, but not in others, after the passage of the Affordable Care Act. Medicaid has always covered more of these at-home services, and indeed has also covered institutional long-term care. So if you're someone who needs someone to come in and help you take a bath a couple of times a week so you can continue to live at home, and you have Medicaid, that would be covered. Whereas if you have Medicare, the only time that kind of help is covered is when you're recovering from an acute illness, or if you have an ongoing skilled need for care, such as in-home nursing or physical therapy. So it's time limited under Medicare, not time limited under Medicaid. The challenge is that not everyone is eligible for Medicaid. And because states are able to define and design their own Medicaid programs, some states have broader coverage with more people eligible, and some have narrower coverage. It is not universally available to Americans across our country. And so we have this big challenge of identified needs and a lack of payment source to make sure that people receive the kinds of services and care that they need. Next slide, please. And here are some data that actually show what the needs of Medicare beneficiaries are. As many of you know, Medicare is the program of health insurance that covers people generally over the age of 65, as well as people under the age of 65 who also have disabilities. So what these data show are that in 2015, more than half, almost half, actually had more than one unmet need for help with activities of daily living. Activities of daily living, or ADLs, are defined as those activities that allow people to stay at home and independent in the community and also to take care of themselves physically. So this could range from paying bills or keeping your house clean, preparing meals, or for the basic activities of daily living, being able to bathe yourself, feed yourself, get dressed, transfer out of bed, those kinds of things. So half of people on Medicare have at least one of these needs related to activities of daily living, which are not covered by the current Medicare program. And you'll notice that almost 1 out of 8, a little bit more than 13, actually a little more than 1 out of 8, about 13%, have either 2 or 3 unmet needs. And those are the folks that are at highest risk of needing services, not getting them, and then ending up in a hospital or skilled nursing facility because they weren't able to get the services that would allow them to stay at home and to get care that they need at home. Next slide. So policymakers in Washington are more than aware of this problem, that Medicare, when it was designed in 1965, really was designed to cover acute illness. And yet most of the care that Americans need, whether it's to stay home or more generally, is related to chronic illnesses, like the ones Karen mentioned: chronic lung disease, chronic heart disease, diabetes. These are illnesses that are very common in older adults and so are very common in Medicare beneficiaries. Earlier this year, Congress passed the Chronic Care Act, which defines something called supplemental benefits in a different way. It allows for supplemental benefits to be offered to Medicare beneficiaries if they are able to benefit from that, not just by getting better, but by either staying healthy or reducing the risk of decline. In the Chronic Care Act, which you'll see from this graphic, went into effect, was passed in 2018 and goes into effect in 2020. The second important thing is that it allows flexibility for health plans to offer certain benefits to some beneficiaries, but not requiring that it's uniformly available to everyone. In other words, if you have a patient with diabetes, or if you're a person with diabetes, in the past, the health plan would have to offer everybody in that plan access to those same diabetes services. Now, you could actually tailor the benefits to offer certain services only to people with diabetes, or only to people with diabetes that meet certain requirements. So this gives a lot greater flexibility to health plans to design supplemental benefits and to target populations in a new way than they've been able to in the past. Because this doesn't go into effect until 2020, the current Centers for Medicare and Medicaid Services, or CMS, in their call letter, which is the instructions they give to health plans regarding how they should define their benefits each year, in their call letter earlier this year, they said you could apply these supplemental benefits definitions, and the flexibility requirements were also included, so that health plans for 2019 that cover Medicare Advantage beneficiaries could begin to offer these services and benefits, and not wait until 2020 to put in place services that arguably could help people stay at home, heal at home, and age in place. Next slide, please. Now, of course, CMS doesn't want to just say, do whatever you want. And so they said that eligibility has to be clearly defined. So if you're going to offer a supplemental benefit, it has to be really clear who gets it and what the criteria are for eligibility. And you cannot use these services as a way of inducing enrollment. So you can't make it such an obvious benefit to a select certain group of people that you're clearly just trying to buy their enrollment. And so this is the information that plans were given in April. By June, they had to submit their bids, which is their explanation to CMS of what they're going to include in their benefits packages for 2019. And CMS, in its guidance that came out I think in May, actually, late April, early May, basically said, here are the kinds of things that we think you could include under supplemental benefits. You could have in-home support services, like a home health aide to come in and help the person take a bath. You could have transportation for non-urgent medical care services, so to doctor's appointments or to treatments like physical therapy. You could have home-based palliative care, so not just paying for physician visits or nurse practitioner visits, but also being able to pay for chaplain visits or social worker visits or kinds of services that are included within palliative care programs that are traditionally not covered under Medicare fee-for-service. You also could do home and bathroom safety modifications to make it safer and to reduce risk of falls. And you could also provide support for caregivers of enrollees. And this is, for example, things like respite care. So you could actually pay for someone to come into the home to spend time with the person so that the caregiver could go out and do other things. Or you could pay for something like adult day health care, which is like a senior center. Some have medical services, some don't, but basically would allow for the health plan to define the eligibility and offer respite by having the person who's getting care go to a center for a day or a couple days a week so that the caregiver can have a break. And this is not a complete list. There are many other types of benefits you could consider offering. For example, nutrition. Maybe you offer home-delivered meals for certain people. So there's a lot of opportunity here to really be creative in defining what's going to help those beneficiaries stay home, stay safe, keep them out of the hospital, keep them out of nursing homes, really accomplish the goals that we all have as individuals and for our families, as well as the goals from the health plan's perspective of doing this in a way that helps keep their beneficiaries healthier and avoids potentially preventable expenditures or utilization of healthcare services. Next slide. So in the call letter, as I mentioned, there's this really important reinterpretation where they allowed for flexibility in terms of what certain people could get from the plan that other beneficiaries may not be able to get. For example, if you reduce cost sharing for certain covered benefits, like testing for diabetes control, or if you offer specific tailored supplemental benefits, you could create a program for someone with Parkinson's disease, which I'll talk about in just a minute. And you can offer different deductibles as long as it's defined by medical criteria in terms of who qualifies for those lower deductibles. So, for example, patients with diabetes, in order to meet quality measures, have to have blood testing and urine testing, blood pressure measurement. You can begin to offer low or no deductibles for those patients with diabetes to encourage them to actually access those services. Next slide. So why would health plans want to do this? Most of them are doing pretty well now, and it's unclear potentially whether these costs of offering these new benefits will pay off in terms of reducing the costs that the health plan pays for today. As a reminder, enrollment in Medicare Advantage is growing and is increasingly competitive. So in 2018, there are over 20 million Medicare Advantage members, which is about 34% of all Medicare enrollees. And the prediction is in 2019, that number is going to go up to 37%. So about a 10% growth in the Medicare Advantage population between 2018 and 2019, which continues a trend that has been happening over the last 10 years or so. For health plans, government business, which includes Medicare, Medicaid, certain state programs, is becoming an increasingly important source of revenue and margin. There's increasing competition for those Medicare beneficiaries who are entering into the program. There are new entrants, so there are new health plans that are developing Medicare Advantage programs who have not been in the market before in some cases, or existing health plans that have been in the market for a long time are now really strengthening and adding to the Medicare Advantage operations because of the recognition that the growth as our population continues to age will be in government-sponsored programs like Medicare. In addition, the health plans that have been doing this for a while, as well as the new ones, understand that star ratings, those are the quality measures, are difficult. And so even though they want to enroll more members and potentially by tailoring programs for patients with certain illnesses, they would attract more of those members, they have to be careful about how they do it so to make sure that they maintain those quality ratings. One of the unanswered questions so far, because this is the first year that this can happen in 2019, is whether these non-medical supplemental benefits will really be an opportunity for plans to differentiate themselves from others. Will the health plans that offer these supplemental benefits that allow people to go home faster from the hospital potentially or avoid hospitalization altogether, will they be used to target marketing towards beneficiaries that are already using hospital services or at risk for hospitalization? Will they target sort of lower deductibles and lower costs for certain members who may have been reluctant to join Medicare Advantage in the past and might have stayed in fee-for-service Medicare because they wanted to have the flexibility of going wherever they wanted or getting services that they needed the way they wanted to obtain them? Will these health plans be able to really differentiate themselves from the other plans And will they also address the so-called social determinants of health, those non-medical factors that have a big impact on people's health? The things that I mentioned earlier in the supplemental benefits discussion, things like nutrition, transportation, something I did mention, financial support. Will these new benefits really help the plans define themselves differently than a traditional Medicare Advantage plan? And will they also be able to make an impact on the medical costs and the quality of the care and the quality of life that those members have? These are the questions that plans have been considering as they've been deciding what their strategy is going to be towards supplemental benefits for 2019. Next slide, please. For those plans that choose to go ahead, there are a few challenges, and let me just highlight a couple of them for you. Certainly there's financial risk. There's no guarantee that just because you invest in a new program for transportation, that will ensure patients will go to their primary care physicians and get good care and not need hospitalizations. There's real financial risk. There's also this question of adverse selection. And by that I mean, will you attract patients into your plan, members into the plan, who are sicker and more complicated and therefore have higher medical cost experience, which you may not be able to manage by adding in these new benefits? And if you add too many of those members, will there be a challenge in terms of the overall financial stability of the plan? These are important questions that actuaries worry about a lot. Another sort of dimension to this is not just the financial and the actuarial questions about the population shifts, it's really operationally, how do you do this? So if you're a Medicare plan, for example, Medicare Advantage plan, and you've never offered a transportation benefit before, how do you define who gets that transportation benefit? How many rides are you going to cover? Who's eligible for those rides? How do you know that they're being used for the physician visit, for example, rather than for a trip to the grocery store? Are there medical necessity criteria that you're able to deploy and implement in a consistent way that meets all of the requirements? Operationally, the network development piece may be difficult too. You may not have credentialed transportation providers, for example, that you can work with. You may not know who that network is or have figured out who the right companies are that will be able to bill you properly and contract with you in a way that makes sense, because health plan contracting, as we all know, is unique. How is that going to happen? And then anytime you do anything in the home, a little more out of sight, out of mind, it does increase the risk of fraud, waste, and abuse issues. So you can imagine the person who said that they were picked up by the transportation company never actually got that ride. That transportation company gives a little piece of that action to the member and pays them and then submits the bill. So there's opportunity for corruption, in other words. And health plans have to think through how to do that anytime they offer a new benefit. The other reality is, from an actuarial perspective, is that we haven't offered these at scale. So there are lots of studies, for example, of home-delivered meals, the whole food is medicine movement, if you will, which I personally think makes a lot of sense and has a lot of impressive data. We haven't seen sort of statewide or national programs. What we've seen are a lot of smaller programs that are very promising in their earlier stages, but we don't have 10 years of data to really look at to see what the impact of those programs are in a Medicare population. And that's really what's going to be required, is understanding what that actuarial risk is and whether the plan is willing to take that risk. So in summary, there are a number of barriers to plans that would keep them from offering these new supplemental benefits for their members for 2019. Next slide. So I just wanted to share with you two patient examples. This is the first one about how this could work. The first example I'm going to share with you is how supplemental benefits may help for people with certain conditions. This is an example of Helen Jones. This is based on a patient we actually managed at CareCentrix earlier this spring. She was a 71-year-old woman with chronic obstructive lung disease. She was hospitalized for pneumonia. She's now requiring chronic oxygen to keep her blood level of oxygen high enough. And she was recently discharged home after hospital stay. She's still taking medicines for the pneumonia, and she's a little deconditioned. She's out of shape because she's been in bed for a long time. Her needs included home oxygen, home physical therapy, help with meal preparation, and she needed transportation to get to her follow-up physician visits. And we know that if she has a follow-up physician visit within 7 days, she's much less likely to be readmitted. When our nurse care manager who was working with her, we have telephonic nurses that do outreach to patients after discharge home, asked her, what is your goal? Her goal was not to get to the follow-up physician visit or to keep her blood level oxygen above 90%. It actually was to get out into her yard, to be strong enough to get out of her home and to fill her bird feeder. So this was spring in New England, and she wanted to be able to get outside and was weak and a little short of breath and wanted to know what we would be able to help her do to accomplish those goals. So under the current benefits that she has in her traditional Medicare Advantage plan, she certainly got home oxygen, she got home nursing visits, physical therapy, and personal care. These are all paid for through the Medicare Advantage plan. Personal care meaning some visits from a home health aide. There may be community resources in her community, so we were able to find out that there were transportation resources, and our nurse referred her to the right people, and so she was able to get rides at a low or minimal cost. Unfortunately, those services, in terms of the Medicare covered services, except for the oxygen, are going to go away after a limited time. Once it's clear that she's gotten sort of the optimal benefit, her access to home nursing, physical therapy, and personal care are going to basically go away. In a future state, however, she would be able to, of course, get the oxygen, nursing, physical therapy, and personal care as she would today, but also could get home-delivered meals, and perhaps even home-delivered meals that are targeted to her specific condition. So certain people with chronic obstructive lung disease, especially those who have more of an emphysema type of profile, they use a lot of calories, and they need to have caloric supplementation, and they can lose weight very easily, especially in the setting of an illness like she's just been through. So we might be able to look at her and have a nutritionist evaluate her and understand that she would need, a higher caloric density meal for the first 2 or 3 weeks after she got home. We might be able to get her transportation, not just for the visits during the time she's recovering from her hospitalization and her pneumonia, but more generally and over time. And potentially could even pay for a home modification, so a ramp to make it easier for her to get back into her backyard to fill the bird feeder, and not just require her to continue to go down steps and navigate that with a walker or wheelchair if that's what she's using currently for mobility. So really you can see how supplemental benefits for her would make a big difference in the short run potentially, but also longer term, and allow her to stay home and avoid hospitalizations again or readmissions in the future. Next slide, please. This is an example of how uniformity flexibility, so allowing plans to shape specific benefits packages to the needs of certain patients, might actually make a difference for someone with a chronic illness. So James Smith is a 68-year-old with Parkinson's disease. Because of his Parkinson's, he has a little bladder dysfunction. He has mild cognitive impairment or dementia. He has a history of falls. He's been admitted to the hospital several times this year for bladder infections, which is probably related to the bladder dysfunction, and most recently in April. His wife is his caregiver, and she's struggling to help him meet all of his care needs. What he needs now coming home after hospitalization for a bladder infection is physical therapy to get him strong again. And the patients with Parkinson's are especially prone to difficulty with movement and so easily become deconditioned when they're acutely ill. He needs help with bladder care, making sure that he's keeping things clean to reduce his risk of reinfection. He needs help bathing and with medication management. His goals, when asked, are really to make things easier for his wife and to stay away from the hospital. So two very clear goals. Today, under current Medicare Advantage, he would get outpatient physical therapy and visits to his doctors and time-limited home physical therapy if necessary. He would get hired. They would hire help 1 to 2 hours a week that they could afford. And in the case that we managed, they were talking about getting rid of those folks that couldn't afford to do it long-term. That allowed his wife out of the house to do some errands. And he got a personal emergency response system, which is, the help I've fallen and can't get up button that's worn on the wrist or a pendant around the neck, basically to help him stay safe if he were to fall. He's thinking about giving that up, however, after the first week or two at home because it's expensive. It's $30 a month or $35 a month for the particular device that he has. In the future state, you could see where he could have home nurse practitioner visits that he would be eligible for specifically under a Parkinson's disease specific program. Home modification could look at bathroom safety, raised toilet seat, grab bars, shower chair, those things that make it easier for him and reduces risk of falls at home. And the bathroom is the place in the home with the greatest risk of falling. Respite care, so having an in-home aid daily, or maybe an adult health program 1 day a week where he would get out of the house and get socialization, which would be good for him, and give his wife some respite, a little bit of a break. And potentially, some of the new plans would offer payments for personal emergency response systems and also allow for home activity monitoring systems. These are passive monitors in the walls that could tell when he fell down or could tell when his activity level changed, and it might be good to trigger an outreach from a physician or a nurse or someone just to check in and see how he and his wife are doing. So you can see where, if a plan chose to, they could create a Parkinson's disease specific program with a new benefits package, and they would not have to offer to everybody, but just those with Parkinson's disease who met certain criteria to get these new benefits. Next slide. So who benefits from this? I'm not going to go into all of these squares, but basically the patients and their caregivers certainly benefit, their families benefit. They get more benefits, allow them to stay healthier at home. The challenge is going to be picking the right plan for them. It's already complicated for people to choose Medicare Advantage plans, and now they're going to have even more options. And it's not clear that just because a plan offers it this year, that they're going to be in it next year. So I think it's going to make the process of choosing the Medicare Advantage plan a little more challenging. Open enrollment starts October 15th this year and ends in early December. So there's not a long time for people to think this through. And now they have more options. It'll be interesting to see how that kind of plays out. For the health plans, the Medicare Advantage plans, they might actually save money if these social determinants of health focused plans, benefits, actually do reduce hospitalizations or admissions. They could actually save money, and they could differentiate themselves from other plans. They could enhance market share, and most importantly, provide better support for their members who choose to age at home. The cons are financial risk, adverse selection we talked about, and the difficulty of operationalizing some of these new benefits. And the questions that we're going to wait to see are sort of, does this really work? Will they be able to differentiate themselves enough to attract more market share? And will that justify the financial risk potentially that goes with these new kinds of plans? For the health systems, this is going to be great for people who manage older adults. The geriatrician, I've done this for a long time, love to have access to these services for my Medicare patients. The challenge is going to be, will I know about it? Will the doctor or the nurse practitioner or the nurses who work with them understand that certain people are entitled to these new benefits? And they'll also wonder, is it really fair that only some people get these benefits depending on their plan, whereas others don't? So we'll have to see whether doctors and nurse practitioners and others are able to prescribe these benefits, and whether the prior authorization requirements or other sorts of evaluations will be too onerous and will limit people to access because of that. And the service providers, the people who run the transportation companies, the Meals on Wheels types companies, they see this as a big new market. Home health companies also see this as a big new market. We'll see if they can overcome contracting issues and figure out how to get paid and claims and all the rest of it to make this really happen. And we'll see sort of whether or not the services that they offer are covered and at what level. Next slide, please. So what will the future look like? And I have four sorts of possible choices here. The status quo, Medicare Advantage plans will choose not to supplement the current benefits and will avoid the sort of disease-specific programs. I think this is likely to be what we'll see for 2019 because most health plans didn't have much time to put this together, and we'll want to see what the health plans who did decide offer new benefits package, what that experience is like. We'll see some people who see this kind of like a new duals. You know, some of these, as I mentioned, a lot of these benefits, these supplemental benefits, are covered by Medicaid today, and there are plans that care for people who have both Medicare and Medicaid eligibility. We'll see if the Medicare Advantage only plans kind of use that model to offer these sorts of supplemental benefits to their members. There are the chronic special needs plans. There are currently today small enrollment, but out there special needs plans that focus on people with certain disease states, like heart disease or lung disease. We'll see if this is a model people adopt. I don't think that's going to happen, but we'll see. And then I think, you know, the fourth choice, and I've asked audiences in the last couple of months what they think, and this is the most popular, so it has a red circle around it. We'll see a mix depending on local plan choices and availability, how much local competition there is, Medicaid enrollment in that state. what the health systems look like. Some health systems or practices, for example, already offer transportation, so this wouldn't be a big deal if the health plan offered transportation too. So we'll see kind of what happens, but for the near future, I think we're likely to see either the status quo or kind of a mess where, depending on where you are, there are going to be lots of options and sort of it'll vary from place to place. Next slide. And by the way, because October 15th is open enrollment, we're already seeing the results in the sense that some plans are announcing what they're going to do. On October 15th, we will be able to go online and look to see what these offerings actually are in more detail. But we'll see like how many of these plans offer digital care at home, so covering telehealth, or pay for house calls or encourage house calls by nurse practitioners or physicians or community health workers. How many will focus on treating acute illness at home or hospital at home? And how many will go for the palliative care at home option, which is potentially coverable under supplemental benefits, and support advanced illness at home? So really working on identifying symptoms that can be better managed in the home and providing services not only for people who have hospice, but people who have palliative care at any time in their disease trajectory and can benefit from these programs. These are the things that we're working on at CareCentrix as well, and including into our existing programs like post-acute care, home health, home durable medical equipment, home infusion, and of course, home sleep management, where we do home sleep testing and provide the devices people with sleep apnea need to manage their condition. So I think to sum up, next slide, please. Before we get to the resources and questions, to sum up, it's a really interesting time right now. In the next couple of weeks, we're going to find out what the Medicare Advantage plans have decided. I think many will stay on the sidelines until 2020. In other words, when they submit their bids in June of 2019, I think we'll see a lot more of these kinds of benefits. The early results are that some plans, like one large national Blues plan, is planning to offer for certain beneficiaries who select this package, a certain number of meals that are home delivered, transportation, a certain number of trips to and from medical appointments, acupuncture or therapeutic massage, certain home durable medical equipment devices like shower chairs, raised toilet seats, grab bars, and access to adult day health services. That's one plan's approach. Others are focusing more on transportation or nutrition, home modification. So I'm very curious to see how this works. But to remind everyone sort of what is the goal of all of this, it's really to help people stay at home, to age and heal at home, and to figure out the right mix of benefits that enables those folks who need it to stay home, but enables them to avoid the hospital or nursing homes as well. So that's it for my part of the presentation. Happy to entertain questions, and I think Karen, some of them have been fed over to you. And on this slide, people can see the details of where they can get more information from our website and how to contact me or Karen if you have further questions that we don't have time to address today.
Thanks, Mike. We have gotten some questions in, so let me just start with them. Here's one. Why do you believe that in your conversations with health plans, what you're hearing about most with respect to the new supplemental benefits that are allowable, why do you most often hear about meals and transportation?
I think it's because those are the ones where it's easiest to kind of target and define them. And if you think about the operational challenges of defining eligibility, I think it's much easier to say you can have 20 home delivered meals after discharge from a hospital or rehab setting and after an acute illness, or you can have a certain number during the year that you can choose. And you can contract with a pretty established network of meals providers that have pretty good reputations. And you can see in the literature that there's actual support for what's being called the food is medicine movement, which basically shows that by prescribing nutrition, you can actually help people stay healthier and stay home and avoid hospitalization or long-term care facilities. For transportation, it's the same kind of thing. There's been way more studies, way more experience. This has been a covered benefit under the Medicaid program for a long time. So there may already be local networks that health plans can tap into to contract for transportation needs at scale. Transportation is interesting too because you're seeing companies like Lyft and Uber and others develop healthcare focused services. And you're seeing alignment between health plans at the national level. For example, Blue Cross Blue Shield Association has a national contract with Lyft, the ride-sharing service, that their health plan members will be able to access and offer to their enrolled members. So I think it's because those are easier to sort of manage and relatively lower cost. Compare that to something like home modification. So where are you going to find the qualified home modifiers? Who's going to do the assessment to determine that it's not just a cosmetic improvement to the home, but it actually will reduce the risk of falls and make the home more accessible? It's a little squishier. It's a little harder to find that network, and probably a little bit more difficult then to predict the costs, and therefore something that plans may decide to do over time, but not necessarily something that they're going to jump on right away.
That certainly makes sense, and we'll find out pretty soon if that seems to be the trend in the offerings later this month. Here's another one. How would palliative care fit within a supplemental benefit? And if you think it fits, which you've alluded to before you do, can you provide some examples?
Sure. So palliative care, as I mentioned, is really helping manage pain and symptoms in the home setting. Traditionally, you can get coverage, physicians can bill, nurse practitioners can bill for visits, but RN visits alone without sort of acute illness, without the person being homebound, which is a requirement for home health services, Medicare is not going to pay for that. So palliative care, we know again from the literature that allowing people to access those services outside of electing to use their hospice benefits has been shown actually to reduce hospitalizations and to reduce pain and symptom burden for certain kinds of patients. This has been studied in cancer patients, even in end-stage cancer patients. Palliative care, it looks like, can even prolong life. Even for people who've decided to forego active chemotherapy, if they can get the home nursing services and the things that hospices can provide without electing hospice, if they have earlier access to that, it seems to provide a benefit in terms of prolonging life, which is the ultimate quality measure, of course, but also that life being less burdened by pain and symptoms. And so these in-home programs, which many hospices have wanted to offer, and many of them do, have kind of been looking for a way to, for payment source, because it's hard to establish and run these programs without having payment for anything except for the physician and nurse practitioner visits. And so this opens up the potential to allow existing palliative care programs to get that source that they need and to look at models like in-home nursing, using protocols to drive pain and symptom management. And it's possible there are also private companies across the country that do offer those kinds of services. And that's something that we've looked into, at CareCentrix as well, is to figure out how do we bring those services to the patient instead of bringing the patients to those services. So more to come on that, but I think it's one of the promising areas that hopefully we'll see grow so that people don't have to make the difficult choice to access hospice, because that's the only way that they can get those benefits.
Thank you. Another question. Do you see other opportunities to address the home first discharge approach beyond
Absolutely.
What you and I talked about? Okay.
Yeah, definitely. I think it begins with really understanding the culture and the mindset of the folks in the hospital. And so I think, you talked about how we have nurse liaisons in acute care hospitals working with physicians, patients, families, discharge planners, having that on-site resource to make it easier for the hospital to discharge someone home, just from I can call this person and they'll help me get this person, the patient home quickly. And I think in the past, in some ways, it's been easier to discharge people to skilled nursing facilities because you make one call, you get them to accept the patient. You know that when the patient goes to skilled nursing facility, they're going to be seen by nurses and physicians. If there's a problem, they're monitored and they can be sent back to the hospital to get what they need. Whereas if you send them off into the home, you have to coordinate a home health company that has, physical therapy or nursing. That can be difficult. Then you have to worry about if they have home infusion, it's a separate company. If they need durable medical equipment, walker, wheelchair, hospital bed, that's a whole other thing. So I think if we could figure out how to offer sort of coordinated packages of those home services and make that the easier path, we'll see hospitals sending people home first. And that's, again, the literature is showing that, for example, with bundled payment initiatives, the biggest cost savings with quality improved, by the way, were in the elective joint procedures where hospitals were actually doing just that. They were putting in place before surgery the package of services, the durable medical equipment and the physical therapy at home that was necessary so that there was no surprise when the patient went home. Those services were already booked and they were expected to be in the home, and the patient knew what to expect. And the patient even had classes to teach them this is what's going to happen, make sure they were comfortable and understood that they didn't need to go to a skilled nursing facility after their hip replacement because all of those services would be provided in the comfort of their home.
Thanks. I think we only have time for one or two more questions. So let me ask, in your opinion, how do you feel about these new policy changes available for Medicare Advantage members, and how is CareCentrix responding in the market?
So as a geriatrician, I feel really good because I've realized we've all realized for a long time that these kinds of benefits that help people with chronic illnesses were a big gap. That the only way to get those services at home was if you were coming out of the hospital or were homebound, had a skilled need, that really limited the access for our patients who needed more of those kinds of services. So it's really a great and exciting opportunity. What concerns me a little bit is it's only Medicare Advantage. It's kind of smart in a way for Congress and the administration to say, hey, let's see how it goes with Medicare Advantage, and then we'll think about, should we do this for Medicare fee-for-service? Because that's still where the majority of members are enrolled in Medicare. They're still in the fee-for-service world. So I think it's going to be interesting to see how that plays out. At CareCentrix, what we're trying to do is figure out which of these services should we be able to incorporate into our post-acute care programs, so that a health plan partner that works with us doesn't have to think about how do I contract for transportation or palliative care or nutrition, but rather how can this be included in those services already for the right patients so that we can help the plans gain experience. As I said, I don't think we're going to see a lot of the plans jump on this because it was announced kind of late in the year for them to put it into their bids. And so if they weren't already expecting to do this, it wasn't really feasible or practical for them. But I think over the next year or so, year or two, we'll see more plans who want to do this, assuming all goes well with those who've kind of jumped in. And we at CareCentrix, because of our knowledge and expertise in the home, will be able to simplify some of those operational challenges and really help the plans that decide to change their benefit packages access those benefits in a simpler, more straightforward way.
Great, thank you. I'm going to try to sneak in one more question in the minute we have remaining because it's an interesting one, and that's, are you hearing about any plans that are considering community-based services that aren't delivered in the home, but rather in the community setting, and which could help care transitions to avoid lengthy PAC facility stays or readmissions?
So I think I mentioned one of the plans that's already out there has announced that they will cover adult day health, which is a community setting, and that it's outside of the home. The person can go there for a day, a couple days a week, whatever makes sense for that person. And it gives respite to the caregiver. Importantly, it gives socialization for people who are often at home alone or with one or two people there. And so I think we'll see more of that. And as we gain more experience with other community-based organizations, the local senior centers who can offer adult day health or adult social health programs, we'll see YMCAs that are already offering exercise programs for seniors in many places start to align with health plans. So I do think that there's an opportunity for bringing the member and the patient to those kinds of services because they offer socialization. It is obviously less expensive to do it at scale, and balance that with bringing the care as much as needed to people at home when they want it and when they need it to be at home.
Great, Mike. Thanks so much. I think we've just hit our time.
Thank you. My pleasure. And thank you for your presentation. I enjoyed it.
Thank you.
And thank you, Dr. Cantor and Dr. Johnston. We appreciate the insights, the research, the experience, the key questions, and the perspectives that you shared. And we want to thank each of you on the call for your interest and attention and participation today. Two closing things in our overall support for the HCG theme of guiding healthcare executives through innovation, change, and growth. We are cooperating with the AHIP Consumer Digital Health Forum, December 11th through 13th, and at the close of that forum, we will have a face-to-face roundtable, and it will focus on two of the HCG top 10 issues for 2019, total consumer health and digital health organizations. If you want to attend the AHIP CDF meetings, use our code, which is simply HCEG, and that will give you a discounted registration. Or you can email Juliana Ruiz at, here on the screen, jr@hceg.org for more information on AHIP and also how to register for the Executive Roundtable. Thanks again to CareCentrix for this webinar and to each of you for participating. Have a great day.